Everyone for being here in our acute care advanced room. We have Natasha Pettit. She'll be speaking on antimicrobial stewardship and microbiology, a vital partnership in optimizing antimicrobial use. And before we get started, I just wanted to provide a brief introduction on Natasha. She is an infectious diseases clinical pharmacist practicing at the University of Chicago Medicine. Her current roles include pharmacy director of the Antimicrobial Stewardship Program and clinical pharmacy coordinator for infectious diseases pharmacy services. In her current position at UCM, she works closely with microbiology lab leadership to optimize antimicrobial susceptibility reporting and is involved with hospital-wide laboratory stewardship efforts. She's also involved with CLSI as a member of the CLSI antifungal reporting group and has collaborated with clinical microbiology colleagues in providing webinars regarding partnering with the microbiology lab and implementing updated CLSI guidance. So with that, I'll pass it over to Natasha.
Great, thank you for that introduction. And I will apologize right now that I had a little more coffee than I normally do this morning. It's hard to refuse free coffee when it's in front of you, so I couldn't control myself. All right, so yes, today we're going to talk about ways in which antimicrobial stewardship and the microlab can collaborate to optimize antimicrobial prescribing. I do not have a disclosure slide, but I will just state that I do not have any conflicts of interest with respect to the contents of the information that we are going to review here today. As far as the objectives, hopefully at the end of this presentation, you all should be able to describe the role of the microbiology lab in antimicrobial stewardship, identify stewardship targets in the pre-analytic phase of infection diagnosis, review potential strategies for optimizing antimicrobial susceptibility reporting, and also develop processes to ensure effective use of rapid diagnostic tests. I think many of us in this room are quite familiar with the fact that antimicrobial stewardship can only be accomplished through the efforts of a multidisciplinary team. And so what I've listed here is really all of the key players that we work with on the stewardship team to make sure that we're achieving the goals and outcomes of our programs, and highlighting specifically, obviously, for this talk, our microbiology friends. So namely quite important in terms of establishing guidance for diagnostic testing, which obviously has implications for future decision-making about how we manage infections, and then also, of course, reporting antibiotic susceptibilities and rates of resistance. So when we think about the sequence of events that occur from the point of a provider deciding which test to send to the point where we have enough information to make a diagnosis and make a determination about what appropriate interventions are, you can see that there's some overlap or areas of interest from both the antimicrobial stewardship perspective as well as the microbiology laboratory. And where I think you have points in which there is the greatest potential for collaboration with the microbiology lab and antimicrobial stewardship would be looking at making sure that we're sending the right test at the right time. We know that's very important from a stewardship perspective. If the wrong test is being sent, then wrong decisions can be made about prescribing of antimicrobials. And I think once you're at the end of looking at result interpretation, this is where we can work a lot with our microlab to help ensure that we're providing the right guidance to our clinicians to make sure that they're able to interpret the results of the laboratory tests that are sent. When it comes to antimicrobial prescribing, we know that there are generally 5 Ds, right, to optimize our antimicrobial prescribing. And what I'm going to show you here and what this table is showing is where I think the microbiology lab can certainly contribute to each of these components of optimal antibiotic prescribing. So the first D being diagnosis, obviously sending the right test, as already mentioned, making sure that the specimen collection is appropriate and consistent with laboratory standards. I've also listed biomarker testing, and you might be wondering, hey, that's not technically microlab, but maybe, right, depending on where you are. But also I'm going to show you an example of how you can actually add biomarker testing in to sort of a schematic to make sure that you're optimizing the use of laboratory testing as well. And of course, rapid diagnostics, which is a really hot topic in the world of ID. The second D of antimicrobial prescribing optimization is to make sure you're choosing the right drug. Obviously, we know susceptibility testing from our microlab friends is going to help us make that decision. And we also know we need to work very closely with the microbiology lab as well in terms of providing antibiogram data and that helps with selection of empiric antibiotics. And of course, also through drug-resistant surveillance, that also may help us make generalized decisions about what is an appropriate empiric antibiotic to use, for example. Dosing, we know that minimum inhibitory concentration, or MIC, reporting can be helpful with that in certain clinical scenarios or with certain antimicrobials. That MIC value might help us choose more appropriate or targeted dosing schematics. And this is where we can also work with microbiology or microlab to add comments actually in the actual reporting screen, if you will, of your electronic health record, right? Adding those comments or those nudges to make sure that providers know which is the appropriate therapy to choose, or maybe even nudge them to consult infectious diseases or antimicrobial stewardship if it's a more difficult to treat infection. I think duration, you could actually put rapid diagnostics here as well with biomarker testing. I'll give you some more examples as we move forward in the presentation. And of course, the last D of antimicrobial prescribing is de-escalation. And we know that, how the lab decides to report certain pathogens, if it's clear based on the scenario that it's likely a contaminant, then imposing interventions there to make sure that it's clear to the providers that also we think that this is a contaminant, you probably don't need to start antibiotics. And this is where you can also consider strategies like cascade or selective reporting that helps to kind of direct prescribing to maybe more narrower spectrum antibiotics, or to antibiotics that are only appropriate for certain infectious sources. So for this presentation, these are really going to be the discussion points. I think you could maybe even find some other areas in the process of laboratory diagnostics to having enough information to make decisions about treatment. There's probably a lot of other collaborative opportunities, but for the purpose of this talk, we're going to focus on these three particular items. And the first being test selection, which is the main step in that pre-analytic phase, right? Before we even necessarily know what infection they have, but we have our suspicions and we're going to choose a test to send. So which test is best? And then we're also going to focus on susceptibility reporting as well as rapid diagnostics and biomarkers, which really falls into that post-analytic phase where we're really looking to focus our efforts or collaborative efforts on making sure that we're communicating results in a meaningful manner and also provide guidance for interpretation. So in terms of test selection, or that pre-analytic phase, right? So making the diagnosis, what test do we send? How do we send it? These are the biggest considerations here. And obviously, so test selection, we know this is just simply put, selecting the appropriate test for the clinical syndrome. And then specimen management is whether the specimen itself is actually collected in a manner that's consistent with guidelines, for example, to make sure that the results that we get from these tests are actually accurate and useful. So what are some of the challenges or pitfalls that occur during this pre-analytic phase? Sending the wrong test. And so our examples here are sending a urine culture in an asymptomatic patient, sending that C. diff PCR test for an unformed stool. And we also see a lot of issues with specimen mismanagement. And whilst antimicrobial stewardship is certainly not necessarily the ones to provide this guidance, it's important to work with our microbiology lab to make sure that this guidance is available and it's viewable and it's accessible to providers, so that we can make sure that these tests that are being sent, right, they're going to have significant implications for decision making when it comes to treating infections, right, are actually sent in a way that, again, are going to be accurate and useful from a clinical standpoint. So what are things that we can collaborate on with the microbiology lab during this pre-analytic phase? So I kind of already mentioned we should have guidance, right, on making sure that we're sending the right tests, that we have proper specimen management. So making sure that there is a microbiology laboratory policy manual. And that manual should ideally address test selection. So when is it appropriate to actually send a urine culture? Outline that we shouldn't be sending it in most patients if they don't have any urinary symptoms. It should also outline any details with respect to specimen collection and transport. I mean, how many times do we see a blood culture get rejected, delayed because it wasn't put in the right bottle, it wasn't provided in the right volume? And those are great examples now, because I don't know who else is dealing with this BD blood culture shortage, bottle shortage, but it's something that we need to be a lot more mindful with. So there are guidelines to provide best practices for specimen management. For example, rejecting specimens that are of poor quality. So if it wasn't sent right, it's going to get rejected. Do not report full identification of organisms for which there are more than 3 pathogens present, because that might indicate that we're looking at contamination here. Cultures, ideally, I think we all know this and appreciate, need to be collected prior to starting antibiotics. It's It's important to perform susceptibility testing only in clinically significant isolates. So one thing that we do at University of Chicago, for example, if it's like coag-negative staph growing in 1 of 2 blood cultures, right? Don't even report susceptibilities, because we don't want providers to think, oh, there's susceptibilities, that must mean I need to treat it, right? Because sometimes that's kind of the train of thought. And we should be establishing processes to ensure that specimens are labeled accurately and completely. I think we've all, at least any clinicians in the room, have felt that frustration of seeing a culture result, but then you have no idea where it was from. So it kind of removes the value of that information. I'm not going to read through all of this, but I just wanted to show you an example of the guidance that is out there for example for when blood cultures are obtained, right? So clinicians need to be aware of when is it appropriate to send this test, but then also for nurses and phlebotomists, providing that guidance on how that specimen needs to be collected ideally, because if these steps are not followed, there's a higher chance that you're going to get contamination. Specimen handling is important as well, right? It's got to be taken to the lab. If it's got to be on ice, make sure it's on ice, right? There's a lot of things that need to be followed to make sure that, again, that the sample itself is actually going to be of utility. And of course, providing some guidance on interpretation, for example, helping providers determine whether or not they're looking at the potential of a contamination or not. And as an FYI, there are updated guidelines from IDSA and the American Society of Microbiology that provide that sort of guidance, as I showed you as the example for blood cultures, but for other specimen types as well. So you might want to take a look at that. Okay, so kind of making a quick transition here now to talk about where do I think collaborative efforts between antimicrobial stewardship and the microbiology lab really can potentially have a significant impact. And these are particularly tests that we know are very frequently ordered in hospitalized patients. Inappropriate ordering of these tests can result in substantial antimicrobial misuse. There's a high potential to result in treatment colonization when you have positive results from these particular tests. And overutilization can also have implications when it comes to having to report infection rates from an infection control standpoint, right? So overutilization means an overestimate of some of these infections that we have to report, right? And so I think what falls in that category are blood cultures, urine cultures, respiratory cultures, and Clostridioides difficile or C. difficile testing. So from here, for this portion of the presentation, I'm just going to go through a few examples that I found in the literature of what other medical centers have done in terms of imposing interventions to try to optimize use of those primary targets that I think are good, a fair game for stewardship as well as microbiology lab collaboration. So in this first study, and I think this is getting a lot of attention again because of the blood culture bottle shortage, but out of Johns Hopkins, they actually imposed an intervention where they developed an algorithm to guide blood culture ordering, not only for ordering initial blood cultures, but also repeat blood cultures. And basically, took this algorithm, provided face-to-face education, and developed provider-specific feedback processes. They focused on the impact of this algorithm in adult medical ICU patients, as well as targeting 5 medicine units as well. And to put it simply, so, we don't have a ton of time. I'm not going to do a journal club here. I know every clinical pharmacist in the room wants me to get into the details. And as Sam Aiken said, yeah, I'm not going to go through supplementary appendix 5A for any of these studies. I just want to just put it simply, this intervention, which is relatively simple, right, resulted in a significant reduction in their blood culture utilization rate. You can see it more so in the medicine floors than it was in the ICU. And they looked at whether or not there was a change in mortality, readmissions, or compliance with the CMS SEP1 compliance. And so they found no difference when they implemented this algorithm. This is a lot on a slide. I'm not asking you to read it all. This is just to show you the algorithm. It actually is not as complex as it looks. They just have both the algorithm for when it's appropriate to send an initial blood culture and when it's appropriate to send repeat blood cultures for documentation clearance. And basically all they did is create pocket cards. They put posters up in rooms where the computers were, where providers were placing orders for blood cultures. They provided some face-to-face education, and saw a pretty significant impact on their use of blood cultures. So this is going to be very important. We're looking at doing something like this here at University of Chicago imminently because of this blood culture bottle shortage. Another VA study looked at reducing inappropriate urine culture ordering, specifically just implementing the requirement at the point of order entry to select an indication for why the provider was sending the urine culture to begin with. And they saw a significant reduction in the number of urine cultures sent and no changes in patient bed days or clinic visits because they looked at both inpatients as well as outpatients. I'm sorry if this is maybe blurry. It's blurry on this screen, maybe not up there. But importantly, what it is, right? So this is the order entry screen. So when a provider goes in, wants to order a urine culture, it's providing the education right up front saying, don't do this if they don't have symptoms that are consistent with a UTI, right? So as we know, cloudy urine or discolored urine, those are not technically true urinary tract infection symptoms. So kind of providing that immediate education up front. Don't do this if this is what you think you're ordering it for. But if you still want to move forward with it, because it is appropriate to order this urine culture, and they actually had to select from a laundry list of specific indications for why they were sending it. And then basically, you know, as I was reading their methodology, they didn't exactly go back and audit and everybody, did they select the right thing or not? But ultimately they saw a reduction in the number of urine cultures sent. And so I'm not really even getting into the stewardship metrics here, but I think we all know if we've reduced the number of urine cultures, then we're going to see a lot less use of antibiotics for urinary tract infections. And I say that with air quotes, because as we know, a lot of times UTIs get diagnosed and it's not really a UTI. Okay. Moving on to an example of restricting Clostridium difficile testing. Here, this particular group looked at hospitalized adult patients at an academic medical center. They developed this real-time alert to enforce appropriate C. difficile testing, and importantly, the outcomes reduced rates of C. diff testing, also reduced the rates of testing while patients were concomitantly receiving laxatives within the past 24 hours, and also retesting if the patient had already had a test within the past 7 days. And this is just to show you the example of what that order entry screen looks like, if you will, where some of the information was auto-populated, some of the information required the provider to attest to certain things, like did they actually have 3 or more loose stools per 24 hours? Do they have other reasons for diarrhea? And if any of those parameters were not in line with the diagnosis of C. diff, they were immediately alerted to the fact that this is not indicated. And basically was a hard stop, right? And unless they went back and they changed the answers to get the outcome that they wanted, which I hear, you know, sometimes depending on where you are, people game the system, but when you hold people accountable for that gaming of the system, then you'll see that that will go away, right? And what I mean by that is when you see it, you call them out. They don't usually do it after that's happened. Okay, and then the last intervention, this was kind of cool. This was a recent publication, and this was an intervention that was imposed at the University of Michigan, looking at a stewardship intervention to try to reduce ventilator-associated pneumonia or VAP overdiagnosis. And what they did, obviously including just ICU patients that were mechanically ventilated, this was kind of a multi-tier and multi-pronged intervention here, where they restricted access to respiratory culture ordering. If it was appropriate to order a respiratory culture, then they made sure that they were ordering non-bronchoscopic BALs instead of other less useful respiratory cultures, let's put it that way. And then they also suppressed culture results if there was minimal alveolar neutrophilia. And basically from this intervention they saw a significant reduction in positive respiratory cultures, decreased broad spectrum antibiotic days by a statistically significant degree. And there was really no difference between groups in terms of adverse safety outcomes where they looked at mortality, duration of mechanical ventilation, or mechanical ventilation events. So just to summarize their intervention here, so really they're targeting 3 sort of steps, right, in that process of infection diagnosis to, you know, determination of what therapy to initiate. So with the ordering perspective, they implemented this clinical decision support tool that required that they select any of the 3 indications for why they wanted the respiratory culture. And then they also targeted collection, where, again, as mentioned, they preferred a specific respiratory culture be utilized if it was appropriate to get that respiratory culture. And then they also targeted reporting, right? So if they only reported that result if the BAL sample had more than 50% PMNs. A lot going on in this slide, and I had reached out to the author of the paper just to get some screenshots because I like to show this as an example. But the first image that you're seeing on, I guess, your left-hand side, this alert basically popped up anytime they tried to search out, ordering a respiratory culture. And it would basically say, hey, like VAP gets overdiagnosed and we don't really think that everybody needs a respiratory culture. This alert was actually just to get them to agree to say they were interested in including the patient in the study, right? Because this was a study to evaluate if this intervention, maintained appropriate outcomes. And so basically, if the provider said, oh, yes, I mean, I still want this respiratory culture and sure, I'll take part in the study, then it would take them to this order set. And then within the order set, it would ask for them to provide their indication for wanting the respiratory culture, and then ask additional questions just to really make sure that the respiratory culture that they wanted providers to get, it made sense for the patient. And then if it did, then it took them to the correct order to order the correct type of culture that was recommended. So I'm going to take like quick little breaks here, and what I've done is made a fictitious ASP micro agenda table, but just to kind of outline and recap, I think what are the things that we really need to work with our microbiology lab with respect to the items that we just discussed. So for any of these pre-analytic phase stewardship interventions, I mean, obviously it's going to be important, once again, develop that microbiology laboratory policy manual. If you don't already have one, stewardship, I think, should be involved in helping to review that document to make sure that we are addressing all of the items that would also be applicable to how providers make decisions about initiating antimicrobials. I think it's also going to be an important partnership to identify and prioritize, okay, what are these interventions that we should focus on as a group, right? That, we can't roll all of these out. We can't target urine cultures, blood cultures, C. diff testing, respiratory cultures all at one time. If you don't already have something in place, maybe, look at some metrics, see what your prescribing looks like with some of these indications, and maybe there you'll identify where you should start. And then obviously it's going to take input from all parties to establish that criteria for lab test ordering, how results should be reported, and coming up with what those processes are going to look like to actually make sure that we're restricting or facilitating optimized lab test use. Transitioning now to antimicrobial susceptibility reporting. This is an obvious one where I think any of us in the room who are microbiologists or stewardship folks or really anybody, we are always having to have meetings and discussions about how we report antimicrobial susceptibilities, right? And so some important targets here are going to be obviously if we're changing our formulary of antibiotics, or what susceptibilities report should be based on what we have on formulary for the most part. There are aspects with respect to our automated systems that we have. I think many medical centers now probably have an automated susceptibility testing panel or platform. And so there's a lot of discussions that need to be had in terms of, what are those panels and cards that we have available, and how are we utilizing the information that we get from those systems. And then also it's important to discuss whether or not there's utility in terms of selective or cascade reporting for certain organisms or infectious sources. And then last, I think we do spend a lot of time around the stewardship meeting table, right? Talking about how do we provide guidance in terms of interpreting susceptibility data, because sometimes it's not just SI or R. There's a few other considerations that need to be made, and how do we make sure that our providers are thinking about that. So just a quick comment, though, on these automated susceptibility testing platforms, if you will, just to kind of paint the picture of how complicated it actually can be to come up with a decision, for example, of which panels or cards or list of susceptibilities that we make available through the automated systems that we have in place. And just to point out, so what I've listed are the four main automated susceptibility testing platforms that are available. And you can see that there are more than a handful of gram-negative panels to consider, more than a handful of gram-positive panels to consider. You got to talk with your microbiology lab. Stewardship folks need to be at the table to make sure that you're actually selecting a card that is most applicable and most useful. And this is just to show you how much of a jigsaw puzzle this is. This is just an example, but if you happen to have Vitek 2, you can see that, and this is just looking at gram-negative cards, you're going to have to go through and figure out, wait, is it going to have this antibiotic or that antibiotic? Does it have the antibiotic that I want? There's just a lot of considerations, and I'm speaking from experience on this because our micro lab reached out like a month ago to say, hey, there's going to be new cards. Can you take a look at this? Which one do you want? I can't even tell you how much time it took for me to figure this out. I actually had to input all this into an Excel sheet and go back and do the comparison to figure out, wait, so what do we need? So a lot of considerations go into that. I mentioned that there are 2 additional or specific interventions that you can make to help with sort of directing providers towards selecting the right antibiotic. And one of those options is selective reporting. And this is where you report results for specific antimicrobials that are based on defined criteria that it's unrelated to antimicrobial susceptibility. So the examples is, only reporting certain susceptibilities based on age or a specific source of infection, et cetera. The examples that you can see here, selective reporting is when we only report nitrofurantoin susceptibilities if it's a urine isolate, or suppressing daptomycin susceptibilities if we are reporting susceptibilities on an isolate growing in a respiratory culture, for example. Cascade reporting is a different sort of schematic, if you will. So this is where we report susceptibilities based on the susceptibilities of other drugs. And it's basically designed to sort of facilitate consideration of the use of narrower spectrum agents up front or first. And so examples would be only reporting meropenem if you have a pseudomonal isolate that is resistant to cefepime or piperacillin tazobactam, or reporting extended spectrum cephalosporins for enterobacteriales only if you have cefazolin and or ceftriaxone resistance. And for those who are a little bit more visual, just kind of putting it together. So basically you're deciding different tiers of antibiotics. Tier 1 is going to be your narrowest spectrum antibiotic. Then you only move on to reporting tier 2 if you have resistance to tier 1 antibiotics, and so on and so forth, right? And it will just say, like, whatever you decide to put into these different tiers, this is a big conversation that you need to have between microlab and stewardship as well. And this is just to give you, as an FYI, if you're looking for examples of how can I implement cascade reporting or selective reporting, and what are cases or situations where there's CLSI guidance in terms of what you should be considering. This is all available in the CLSI M100 document in Table 1. So I would recommend looking at the examples that they have there. And obviously, it's going to require some customization according to your medical center as well as what you have on formulary. And as an FYI, this is certainly something that is endorsed by, and I guess I need to slow down and specify, selective and cascade reporting is specifically recommended by IDSA and SHEA in the implementation of stewardship guidelines. So at least kind of the guidelines give a nod to the fact that these are interventions that we really should be considering having in place at our medical centers. I'd mentioned another way that we can sort of influence or facilitate better decision making when it comes to interpreting susceptibility information. I'm just giving 2 examples here. One thing that we do it can be at the point of organism identification, right? So whenever we do identify that a patient is growing Candida auris, right, we know species identification way before we know susceptibilities. And we've had some issues where providers are not really aware of what the Candida auris susceptibilities typically look like, and they keep them on fluconazole. So we decided, let's add a comment that says, hey, this is Candida auris. It is likely resistant to azoles. It's important to have this patient on enokinocandin until you get susceptibility information, and then also nod to our ID consult service that they should probably be brought on board because this is a difficult to treat infection. You could also consider having interpretation guidance once you do have organism susceptibility data, and maybe even use that to provide your dosing guidance. And this is a great example with vancomycin-resistant Enterococcus faecium, or VRE, for daptomycin. As we know, susceptibility is only reported as susceptible dose dependent. Most people who are not in the world of ID do not understand what SDD means when they see that. And so providing that additional commentary like, hey, this is susceptible dose dependent. This is what this means. This means you have to dose a little more aggressively. And then once again, because that dosing is so nuanced, you should probably talk to ID about it, or stewardship. All right, so putting together that agenda of items that we probably want to discuss as it comes to susceptibility reporting. I think when it comes to selecting that AST panel or card, you got to talk about feasibility. Can I have multiple gram-negative cards? Because that's what I asked my microlab. I'm like, I'd like 2 of them to get everything that I want, right? But is that possible? Do I really need to hone it down to 1? Those are things that you're going to need to negotiate with your microbiology lab colleagues. One thing that I do recommend looking at is evaluating the frequency in which antibiotics need to be added on. If you find yourself having to add on susceptibilities all the time, you should probably relook at what card you have, because that's an expense to the microlab every time they have an add-on. I recently joined a lab stewardship committee, and one of the things that was brought up is ID keeps asking for all of these add-on susceptibilities. And when you actually see that dollar amount, it's like, oh, maybe we should have some cards that just give us that information, and I'm not asking for this separate data that also takes a little bit longer to get that information. And I think other things to discuss, obviously, the timeline, if there's enough of a change, are you going to need to develop some education for providers? That's something to discuss as well. In terms of selective and cascade reporting, just negotiating with the microlab, what are those scenarios that you want this to have happen? I will say, from my vantage point at University of Chicago, we have issues with lab resources, and we haven't gotten to get too creative with a selective and cascade reporting. And it's something that actually we have to add to our agenda in the coming months. And then in terms of susceptibility interpretation or guidance, again, just identifying which results are going to require that interpretation guidance, and you're going to need to collaborate and get the input of both microbiology as well as stewardship in terms of what that information or guidance is. I'm kind of running short on time, so I'm going to go through the antibiogram preparation relatively quickly, because I think this could be a 45-minute topic in and of itself. But like, we know what the antibiogram is, right? It's giving us our susceptibility information, cumulative over usually a 12-month time frame. When we prepare that document, obviously we're getting information from our microbiology laboratory colleagues. We want to make sure that that information is accurate and in line with CLSI standards, which are outlined in the M39 document. As we know, there are some specific parameters that really need to be in place, and it's going to take some collaboration with our microbiology lab to make sure that we are following all of these outlined rules, regulations, and provisos as it comes to antibiogram preparation. There's also some guidance and important to consider as a group, whether or not you want to offer enhanced antibiograms. And these are basically antibiograms that are just, based like unit specific or patient population specific. And then there's also the recommendation to consider combination antibiograms for areas where you might be implementing combination therapy, which we sometimes do in our intensive care unit patients. So we have an ICU combination antibiogram for gram-negative pathogens, for example. I will just point out, again, just emphasizing that guidelines support this, and so we should probably give a bit of a prioritization to considering this in terms of, yes, it's great to have an antibiogram, but even better to have these stratified antibiograms. And I do apologize, there's different nomenclature that they use. This is basically that enhanced antibiogram, so important to consider. Have that antibiogram for your hematology oncology patient population. Have an antibiogram for ICU isolates only, instead of just only offering your hospital-wide antibiogram and not honing in on more specific groups. So antibiogram preparation agenda items here, again, you got to work together to make sure that you're following those CLSI standards, right? So just for context, the University of Chicago, it's stewardship that has to put together the antibiogram, but I just work with the microlab to get the data that I need for it. But then we're, as a group, reviewing it to make sure that we are following the standards that are set forth by CLSI. Other things discussed, what is this document going to look like? Where is it going to live? What are the antibiotic organism combinations that we're going to include in it? And then another really important point, and this is why it's so important to have microbiology lab at the table, is that, throughout the year, sometimes something might change with how they report susceptibilities, right? Or there's a change in CLSI breakpoints. And so it's good for somebody to be at the table to be like, why does that number look so low? Oh, wait a minute, it's because we changed the data or how we report something, and then our report was missing some information. It helps to kind of troubleshoot why we're seeing any changes, because we want to make sure that antibiogram data is as accurate as possible. And just to give you a few examples of things that I've come across that resulted in initial frustration of like, what is going on? But it's because something changed throughout the year that, maybe I was at the table for, I actually remember discussing, but I just didn't really think about how that's going to impact the data for the antibiogram. So one example, and I don't remember the logic for this, but like 2 years ago, they decided, let's report susceptibilities for antifungal agents as a footnote to the table that shows up in Epic, right? That is the electronic medical record that we utilize. By moving it into a footnote, that meant that my reporting structure couldn't pull that data because it wasn't in a discoverable field. So I ran that report and I'm like, why do we have 0 susceptibility data for fluconazole and Candida glabrata, right? Well, we look back, they made this change, and so we were able to quickly reconcile that information. Or very recently, we changed our laboratory information system about a year ago. I think we didn't even realize this change happened, but they started actually labeling Enterococcus faecium, if resistant to Vanco, as vancomycin resistant Enterococcus. So what that means is, in this table on the right, like this is the EHR list of organisms that I can pull into this field. You can see it's treating vancomycin resistant Enterococcus faecium as a totally separate organism, and it wasn't even being pulled in, right? So we're like, why does our our Enterococcus faecium looks pretty vanco-susceptible these days, right? No, it's because we were totally missing some important data. Other things to consider, as I mentioned, changes in CLSI breakpoints, that's going to have implications for stewardship in microlab collaborations on susceptibility testing, as well as antibiograms, as well as the addition of new antimicrobials to the list of options that we have. A very quick word on rapid diagnostics. We know that there are several genotypic and also a phenotypic rapid diagnostic test that's available. These seem great on their surface because they provide rapid organism identification, detection of resistance genes, as well as in some cases even phenotypic susceptibilities within hours. The options are multiple when it comes to the potential specimens that we can actually run these on. And you can see that there's a lot of them to consider, and you know, making decisions about which one of these you're going to have available at your hospital. Obviously, you need microbiology lab because it's going to come out of their budget, and they have a lot of interest in making sure if they're going to make these available, there's got to be something in place to make sure that people are actually utilizing the results of these rather expensive tests in an appropriate way. So that's where I kind of outline that's the major challenge, right? There's a lot of them to choose from. But they're costly, they tend to be overutilized. Unfortunately, when positive, they don't always mean active infection. You really got to think about it in the clinical context. And as I kind of mentioned, you really do need antimicrobial stewardship interventions to go along with these rapid diagnostic tests. This is just to give you one example. This is data from a meta-analysis looking at implementing rapid diagnostic tests, or RDTs, with or without a specific stewardship intervention. And basically what this is showing you, so you see that the forest plots, one of them is showing you the culmination of mortality data from various studies looking at RDT implemented in combination with stewardship versus RDT without stewardship. And you only saw a significant improvement in mortality when you added that stewardship intervention to the implementation of these tests. And I will just say that the guidelines do give a nod to considering the implementation of these RDTs, especially for rapid viral testing for respiratory pathogens, as well as blood culture specimens. And we're very excited at the University of Chicago. We finally got a rapid blood culture identification panel, and it's been exciting. And I promised you at the very beginning of this presentation, I'd mentioned that biomarkers can have an important role when we're looking at collaborating with the microbiology lab in terms of making sure that lab tests are being used optimally with the hopeful and positive impact on antimicrobial stewardship. And I give you an example of one particular center implemented a BPA where they looked at procalcitonin plus whether a patient was on antibacterials and whether they had a positive respiratory viral panel. And if they had a low procalcitonin, which indicates a low likelihood of bacterial infection, and then had a positive viral pathogen on their respiratory panel, and they were receiving concomitant empirical antibiotics, they basically got an alert that said, hey, these parameters are present, you should probably reconsider whether or not you need antibacterial therapy. That simple intervention, right, reduced the number of antibiotic days of therapy in the group of patients that they looked at, and also really no difference in the rates of needing to re-escalate or restarting antibiotics after discontinuation. So there's a way to incorporate biomarkers into optimizing laboratory testing as well. So take-home points, I hope I've proven to you. I don't think I needed to, but I did. Microbiology lab does play a vital role in antimicrobial stewardship. It's important to send the correct diagnostic test at the right time, and it's a really important target that both microbiology and antimicrobial stewardship can collaborate on. Antimicrobial susceptibility testing reporting can be optimized through a number of ways, which we discussed. Accurate antibiogram data is going to rely on ongoing transparency in those lab reporting modifications. But we also, too, from the antimicrobial stewardship side of things, have that responsibility for sort of keeping on top of CLSI breakpoint updates or formulary changes, for example. And last, ASP involvement in the implementation of RDTs helps to improve the impact on antimicrobial use and clinical outcomes with these tests, which really highlights, you know, the value and why it's important for antimicrobial stewardship to work with microbiology to make sure that we're optimizing the diagnostic testing that we use on a daily basis to make decisions about antibiotic treatment. And with that, I know I did not give you a ton of time for questions, but that was on purpose. Ha, I'm just kidding. But with that, I'll open the floor to any questions. Thanks. Yeah, like 5 minutes. Yeah, right? Yeah. Or even longer. Oh. Yeah. Oh, the timer says I'm at 55 minutes. Oh, yeah. Oh, okay. Yeah. We have a question in the back.
So I believe you may have addressed this in your presentation. I was looking looking at suppression of select antibiotics in the same class, if, like, for example, aminoglycosides, if gentamicin is sensitive, you don't report amikacin, for example. That should be made mandatory because not a lot of places I see that happening, including my own facility.
Interesting. Yeah. So that's exactly, an example of is sort of right. I said it would be more selective reporting because you're saying, right, if it's gent susceptible, don't report amikacin. Yeah, that's a very reasonable strategy to consider. Yes, absolutely. But honestly, who's using? Yeah. But gent's kind of fallen out of favor too, right? So because we can't even use it technically for Pseudomonas anymore. Yes. Yeah. We'll start with you, but I will not forget that you raise your hand.
So going back to like urine cultures, where we practice, majority of UAs are UA reflex to culture. I guess, what is your opinion on that? Make them always order a culture?
Yeah, okay, that's a loaded question because I think I've been fighting with my microbiology lab director about that for approximately 8 years. I think the jury's not out on that. It sort of depends on what the culture is in terms of sending urine cultures. I think reflexive still is a reasonable strategy, right? Because you're waiting for those specific urinary UA parameters to be present to then even reflex to a urine culture. But then again, I just seen in practice and even our own practice, what is that? What are those parameters? Like we reflex if a white blood cell count is greater than 5 or there's a positive leukocyte esterase. So pretty much everybody goes to getting a urine culture. But if we had like more restrictive criteria for that reflex, I think that's still a reasonable strategy. But that being said, where is the issue with urine culture ordering? It's sending it to begin with. So whether it's a UA with reflex to urine culture or urine culture straight on, you got to have the symptoms, right? Minus the few exceptions like pregnancy and neutropenia, and, urinary tract instrumentation, things like that. So I don't know if that's a great direct answer to your question. Like, I think it's a good idea, but I think you better have criteria that actually makes it worthwhile. And we had a question over here.
So they're ignored for information that's asked for, specifically when we're talking about urines and what kind of indications you have. I'm just going to pick one and move it through, even if it's not necessarily the case with that particular patient. So when you pull reports to legitimize things or to get your data to determine whether or not this was appropriate, how are you guys doing that? Is it more of a very, very much manual process? Or have you determined, just to see if this truly is legitimately being handled?
Yes.
So you can
Yeah.
report it appropriately at your committee?
And I should just be clear though. So those examples that I gave though are not what we are able to do at University of Chicago, because I agree. So I don't know if people in the room could hear her, but kind of talking about the challenges of BPAs and the information that we have providers input. I mean, is it actually what's happening with the patient? Is it accurate? The VA study, if I'm remembering, is the one that had just that, the urine culture indication. They did use it for tracking purposes to see like, okay, what percentage of the time did they say, oh, I ordered it because, this reason versus that reason. But it would require manual chart review to go in and be like, okay, but was that actually what was going on? Versus just having the distribution of responses to that alert. I think that is a huge challenge because it's funny because actually the other day we were having a conversation about implementing a new BPA, but kind of hearing that at our center that's what happens. Like more than 30% of the time, BPAs are evidently just kind of, click. I just want to get this off my screen because I got to move forward. But that being said, we implement a lot of things with ordering of restricted antimicrobials at our hospital, for example, where almost in real time, right? Like we let them order that remdesivir and select the indications for why they needed it, but stewardship's going to look at it within 12 hours because we have an alert built to make sure that they're actually following and putting in responses that are actually appropriate and applicable. So I think it's going to be contingent on like, if you build it, you got to review it and maybe have a real-time solution for reviewing it, rather than needing to rely on, okay, I just want to run a report, because usually a report is only going to get you as far as what did they select. But I guess it depends on how savvy your IT group is, because if they can figure out a way to say, okay, they responded to this and this was actually truly present in their chart, maybe that's an option, but I've yet to see that happen. So, but I understand your question. I think it's a frustration, and I don't know that, even though I've shown you these examples of these really quick fix BPAs and sort of managing what the order entry screen looks like, you know, there's definitely, they're not fail proof. So, question. I'm sorry. I don't, a combination actually. Somehow my microlab director will not let me you know, change the criteria for UA with reflex to urine culture data, but she let me ask for 2 cards, because we were seeing a lot of add-on susceptibilities though. And once you look at that cost for those add-on susceptibilities, she's like, yeah, let's do 2 cards. Yeah. I don't remember that, like, there are numbers and letters, but if you'd, I could probably tell you offline. Yeah. Oh, yeah.
Able to maybe most appropriately leverage biomarkers, things like procalcitonin and disease states where maybe there's a bit stronger data, things like sepsis. We have struggled with that, maybe more so in pneumonia. We're able to use it, but even cell practices all over the place. Have you had any success there?
I'm going to say full disclosure, we do not use procalcitonin. We just never added it. I understand the value. There's, you know, there's growing data to say, sure, it's useful maybe in certain circumstances, but we just never got there. And I think our main reason, and but I do need to look into the latest literature because I haven't bothered to look into it, so we never added it. But in those earlier studies, at least, like it kind of looked like, if you're a medical center where you already do have very long durations of empiric regimens, more than 4 days, then it's useful. Versus, you know, we kind of did a quick analysis of what our empirical duration of antibiotics looks like. And, you know, I'm going to put in a plug for our super strong clinical pharmacy team. Most antibiotics do not get continued longer than they should in most cases. I won't say across the board, but I just know every clinical pharmacist is like, on their list of things to do they need these antibiotics still? So I think what we're seeing, just generally speaking, we didn't have super long durations of empirical antibiotic regimens, so we just didn't think to bring it in. So unfortunately, I cannot answer your question about if we've been able to successfully do it because we don't. Yeah. Another question here, sorry.
The addition of adding on MICs, like additional costs for labs. I know some EHRs are also for the MICs for some devices. Just wasn't sure. Thoughts about it, but sometimes people like we have to like call the lab to like get that MIC.
Oh, interesting. Yeah, and no, I wonder if that's a policy thing too, because I remember we had that issue where, like, for some reason they didn't think providers needed to see the MIC. Like they just gave them SI or R, and then we'd be on rounds with our ID fellow, and they'd be like, "How did you know that MIC was whatever?" It's like, it's right there, and we realized, oh, you guys have a totally different Epic view for these results. I think that's an interesting strategy of. I mean, I would wonder, is it just it's suppressed and it's actually done, or it's asking the lab to do extra work to get that MIC data?
From the VA, we don't see that calling the lab.
Wow. Okay. Yeah. I mean, obviously, I don't have that experience because, like, I'm used to. I mean, our process is you get the susceptibilities. You're not just getting the interpretation. You're getting the MIC. You know, I would just wonder, you know, if culturally speaking, maybe somebody thought providers don't need to see that data. I never understood why when our microlab tried to, you know, say that there was a reason for why they were doing that. But unfortunately, yeah, I don't have experience with that. I mean, I think in most cases, like, that data is there. They just need to report it. And I think many microlabs would prefer not getting a phone call, you know, for every time you need that information. So, I mean, yeah.
I went from an institution that used Epic during my PQI 1 year to PQI 2 now having.
Yeah. I mean, that's an interesting, yeah, an interesting limitation, I guess, of the, you know, EHR that's used, or maybe it's a policy thing though. You know, 'cause I wonder if that data's there. They just need to hit, you know, go ahead and share this information. Question?
Public health perspective, I see the antimicrobial acceptability reports across a wide spectrum of healthcare networks. It's incredible how much they share, what information they, what they got, as well as, you know, the specific, you know, antimicrobial agents that they include, how they represent resistance, whether or not they include any kind of references. It could be more smooth area. And also, that is something that we kind of want to have more universal, especially with intercellular transfer of information that we can and be challenging for people to where you can find the information that they need.
Any other questions?
You know, in those patients who get the wrong antibiotic, get the wrong dosage, and that can impact the body. And this should be standardized across the board. And I don't see that happening anytime soon.
Yeah, I agree. It's astronomically, there's a huge spectrum of what information clinicians actually have available to them from the microbiology lab. And this is a very interesting conversation because I almost wonder, like, should CLSI think about at least providing guidance to standardize that at medical centers, and what are some of the things that should be prioritized? I think that could be a start, but a very interesting conversation. Yeah.
I actually agree with you because some of the times that I've told physicians and the way that they interpret the MIC can be black over here and white over there.
Yeah.
You know what I mean? And it's just like, oh no, that's not right. You know, and so sometimes you'll have like directors of some of these labs that just tell them that it's acceptable, intermediate, or it's resistant. That's it. Stop worrying
Yeah.
about what the numbers say because they want to make decisions based on numbers.
Right.
And it may or may not be irrelevant or relevant.
Yeah.
And so that may be one of the reasons why yours took it out of your.
I just started.
That's the rationale why we don't, our lab doesn't record it. Because it muddies the water. Yeah.
Okay. Yeah.
Resistant intermediate.
Yeah, I think there's a lot of sides to it, but I will say, like, it would be great if there was guidance from some sort of governing body, because until that's there, then you know, it's always going to be kind of a heated discussion between microbiology labs, stewardship, and clinicians. You know, what and how should we be reporting this information? And if you have some sort of guidance, at least that suggests this is probably best practice, then maybe that gives us a little bit more leverage to accomplish a little bit more standardization. So, all right, awesome. Thank you so much.